All right. Well, welcome to Out and About with PD. PD stands for Program Director, and that's me, Erica Narducci. I am the Program Director at Cancer Support Community Delaware. When we were fully virtual, I started this video podcast to bring you relevant topics by interviewing interesting and informative people in our community and people that you weren't maybe aware of because you weren't out and about much yourself. And even though we're moving back to being more in person and beginning to feel kind of like normal again, we have continued this program because there are so many interesting people out there in our community, and today is no exception. So thank you for joining us for episode 22, What Are the Odds? With Rob Wecker. Rob, thank you for joining me.
Thank you for having me, Erica.
So Rob has worked in pharma for over 30 years. His biography is very impressive and very extensive. And he's going to share a little bit about some work things today. But Rob is also a cancer survivor. And because June is Cancer Survivor Month, I have asked him to come and share some of his odds-defying journey with us. So let's jump right in. You call yourself a surthriver, which is kind of a tongue twister for me, but surthriver, what do you mean by that?
Yeah, it is a bit of a tongue twister, but let me just give sort of a quick background, at least as far as sort of my diagnosis. So I'm a 3-time cancer survivor. I was diagnosed with testicular cancer in 1991, with a liposarcoma in 2010. And I sort of jokingly call those two cancers my practice run, because in 2014, I was diagnosed with pancreatic cancer. And I consider myself actually lucky because each of my diagnoses were done early. And a favorite phrase of mine is early detection, because from my vantage point, that gives cancer patients the best opportunity possible to be able to fight the disease. For me, surthriver was really more about a mindset, right? It's trying to get sort of beyond the cancer and beyond just being a survivor, and trying to show that I had a bit more control of my life, and wasn't letting the cancer dictate my life. Now, to be honest, it's an ongoing challenge. I don't know how successful I am in the surthriver aspect of it, but I am a survivor, and I'm 9 years out from pancreatic. So, I count my lucky stars every day for that.
Excellent, thank you. So tell us about your pancreatic cancer. How was it found?
Yeah, it's interesting because at the time, I really didn't show a lot of the common signs of pancreatic cancer. So a lot of pancreatic cancers have jaundice, or they experience back pain. I wasn't having any of those. I did have some GI related issues, and upon retrospect, including things like oily stools that I perhaps didn't pay as much attention to. Another key common early sign is weight loss. But it's interesting because I was trying to lose weight, right? I had my Fitbit, I was tracking all my steps, everything else. So when I was losing weight, I was happy. It wasn't unintentional. Perhaps I was losing a little more than the diet I was on suggested I should be. So for me, as I started to have some GI issues, I went and saw my primary care physician. And, on that visit, we sort of had a conversation, and then he decided to put me on a probiotic, thinking that maybe that would resolve some of my GI issues. They sort of continued, and after 6 weeks, I sort of went back to him and then said, well, maybe we should try to change your diet. So he put me on a low-fat diet to see if that might improve some of my GI-related issues. And finally, sort of my wife, pushed me and said, hey, we can do this forever, but, you should go see a GI, and you should go get a scan done. So this all started in January. Probably in May, I actually went and had a scan. And at that point was when I was diagnosed with the pancreatic. But to be honest, Erica, for me, I mean, in retrospect, I sort of beat myself up because I really didn't practice what I preach. Right. So the way the health system currently is structured, it's always the assumption that, well, let's assume you have sort of a minor ailment, and let's try to resolve the minor ailment, and let's not assume that it's sort of worst case scenario. And for me, given my background, given I had already had cancer twice previously, I personally should have turned that on its head, right? I should have demanded, if you would, the scan be done first, and let's rule out the worst case scenario. Because what it ended up costing me, it cost me sort of 6 months before I actually started to think about pancreatic cancer treatment. So shame on me for not being a bit more aggressive as a patient.
But when we look back, our vision is always 2020. That's what I always say, and try to not to beat myself up too much. And
Right.
speaking of numbers, like 2020, you told me you're a numbers guy. So tell us about the numbers associated with your cancer.
Okay, so for me, there are really 3 sort of key numbers: 6, 15, and 80. And no, I can't. 6 times 15 is 90, so it doesn't quite work out. But 6% of people who are diagnosed with pancreatic cancer make it to the 5-year survival rate, right? Only 15% of pancreatic patients are eligible for surgery. The surgery is called a Whipple procedure. But usually the problem with pancreatic is because it's caught so late, the cancer usually has spread or is inoperable. So again, for me, the fact that my early detection was good made me eligible for that. And finally, and this is probably the most sobering number, is 80. And then at the time of my diagnosis in 2014, 80% of pancreatic patients died within 1 year of diagnosis, right? So as I sort of take a step back and thought about being presented those numbers at my time of diagnosis, it basically just told me that I needed to be very focused. I needed to be very aggressive in whatever treatment I was going to pursue for my pancreatic cancer.
And I think that that's very sobering, especially hearing 80%, don't even make it through the first year. That would be scary. So you said to me that you are driven to help patients make informed decisions. And I know this comes from your experiences that you had. So tell us about how you made informed decisions, because now you had a lot of decisions to make after you've been diagnosed.
Correct. But let me sort of take a step back. And actually,
Okay.
this is, for me, has evolved into what I consider my true North Star as a patient, right? And it's really that throughout the patient journey, patients need to be enabled to make informed decisions at every point in time through their journey. And again, data will change over time as you get more information, and the perspective will change. But at any given point, really driving to be able to make an informed decision. And there's a lot that underlies those 2 words, right? Because you really, for me, it's about, well, patients need to understand all the options that are available to them. Both, what is the current standard of care? Are there any clinical trials that might be available? Are there any, unusual medical options that might be out there? And for me to make a decision, I need to really understand that whole spectrum of possibility. I really need to understand, okay, well, what are the risks and what are the benefits associated with the various treatment options, appreciating that an approved drug has much better knowledge and information about what works and doesn't work versus something that you might do in a clinical trial. So you have to sort of build in that expectation or that buffer, if you would, that okay, the knowledge isn't that good, but you need to sort of make an assessment. And then what's the likelihood of occurrence of those benefits and risks, right? And finally, one of the other things about making informed decisions is, I'm going to call it the understanding of the language, right? That it needs to be plain language. It needs to be understandable for patients, because most patients do not have a PhD. Most patients do not speak medical jargon that our doctors speak. So it's really trying to clarify it and make it understandable for me as a patient. So for me, I mean, one of the key decisions was early on, which really was, do I go on a clinical trial or not? And again, I was lucky because I was detected early and I was eligible for surgery. So I had a lot, having worked at a pharma company, I had a lot of fairly knowledgeable people who were advisors to me. And my wife actually has a cousin who's a radiation oncologist, and her husband is an oncologist, and they, of course, became my favorite relatives. And they were certainly willing to share their perspective and knowledge with me and insight. And most of my advisors, to be quite honest, suggested that, well, you're eligible for surgery, you should just have the surgery as soon as possible. And the clinical trial I was interested in was structured in the following way. It was 1 round of chemotherapy first, followed by the surgery, then 8-week recovery from the surgery, then 3 more rounds of chemotherapy, and then radiation. So the real question, the real sort of fundamental difference was, okay, do I do the surgery right away, cut the tumor out, get rid of it? Or do I do the trial where I'm not going to, I'm going to let it, if you would, be there for another month while I go through an initial round of chemotherapy and then have the surgery? And just quickly, I mean, the trial I was interested in was basically, it was a high vitamin D dose trial, and that would be given along with the chemotherapy. And it was very early, so there wasn't a lot of information on how effective it was going to be. And for me, Erica, it sort of came down to, I mean, there were really 3 reasons why I defied most of my advisors and opted to go into the trial, right? The first one was that I thought the vitamin D would help stabilize the tumor, right? And make it, if you would, may shrink it, but more to the point, would make it more stable and easier for the surgeon to operate on that tumor, right? The second reason was really just the desire to be aggressive in the treatment. And I didn't really see a lot of the downside to trying this trial. So again, my mindset was sort of to try something a little unconventional, if you would. And the last reason, and this isn't scientific and doesn't necessarily align with my background, is that, excuse the way I describe it, but I thought about having a round of chemotherapy first as a way to sort of scorch the earth, right? And what do I mean by that? Really thinking that, okay, so if I scorch the earth first and then have the surgery, if there are any little fragments or bits of cancer floating around, it would be harder for them to metastasize or grow or anything else, as opposed to if I just have the surgery and then I have 8 weeks of recovery where, okay, well, maybe somehow there are little fragments and they're going somewhere or doing something. So in my weird way, I sort of felt a little more confident having scorched my earth before, the surgery.
Well, and thanks for explaining that, because I think we all, in being a cancer survivor myself, I made decisions. Sometimes it's based on just what you feel is going to be the right thing. However, your mind, helps you to figure it out or explain it to yourself. I do love that description.
No, I think that's right, and I think there's like I said, it's certainly not scientifically based, right? In terms, because I'm sure, well, I know my scientific people were telling me, well, no, you should get it cut out. And for me, I just had this vision that, okay, I didn't want to, the worst thing, as most cancer patients know, I mean, you don't want it to metastasize if you can avoid it. So for me, that was a way to potentially avoid it.
Right. So you're going with the clinical trial, you know what's going to happen. So describe a little more about that treatment journey. So what actually did it include?
Yeah, so basically if you would, the chemo phase was sort of like 1 month. So it was 1 round of chemo. And for me, the chemo was gemcitabine and Abraxane. So I would get an infusion of that once a week for 3 weeks, and then the 4th week would be off. I then had vitamin D infusions. So those occurred both with the actual infusion of the chemo, but also 3 times a week. So I was getting very high doses of vitamin D. It's not like I could have gone off the shelf and eat. It would be like trying to consume 50 pills or something. So it was very high doses of vitamin D. So I did that for 1 round. I then had the Whipple procedure, which is about an 8-hour surgery where they basically pretty much replumb your around your pancreas. If you have parts of it working, great. But it's a very extensive surgery to try to go around where the tumor was and have your pancreas be as functional as it potentially can be. For me, so then there was an 8-week recovery time, and then I had 3 more rounds of chemotherapy. And after that was done, I had 28 treatments of proton beam radiation, which we can get into. There's an interesting storyline there, but I'll hold off on that.
So you know where we're headed.
Yeah, I think so.
So that's quite the load of treatment for anyone who's been through a cancer journey. That's a lot. It's a little bit of everything: chemo, radiation, and surgery as well. So share with us some of the biggest challenges, like medically, as you're going through all this. What was challenging for you?
Okay, and I assume medically we're not talking about. I'm gonna keep it to medical and not psychological, right?
Yes.
So okay,
that might be my next question.
maybe we'll see. So for me, I guess I would start the story with pain meds, right? So the Whipple procedure is very painful. It's fairly invasive. There's a lot of cutting, pulling of muscle, everything else. And I was on a clinical trial. And being on a clinical trial, protocols are written and protocols need to be followed, right? So post surgery, I had my pen, that I pushed for pain medicine to my back, that I was allowed to sort of control my own, but they sort of control how much you can do. And that was like for the first day or so. And then it became an issue around, okay, so every 4 hours, the nurse would come in and would offer me, how's your pain? And I could take some OxyContin for my pain. And basically I could take 1 or 2 pills every 4 hours. And, I kept remembering that all the doctors and everyone else and a lot of friends I talked to were always reminding me, stay ahead of the pain curve, right? Don't fall behind the pain curve, because then it gets really bad. And so the nurse would come in and she said, okay, you could have 1 or 2 pills. And, I'd say, well, my pain's not too bad. Maybe why don't you give me 1 pill? And if it gets worse, I'll call you and I'll take the other. And she was very quick to say, no, that's not your option, right? That basically the way the protocol is designed is that I'm going to come in every 4 hours. And you can take one pill, or you can take two pills, or you can take no pills, but I'm only giving it to you every 4 hours. So of course, I took two pills because I wanted to stay ahead of the pain curve, right? By the time I left the hospital, I was on 12 OxyContin a day, right? So for me, I became obsessed with how would I wean myself off of this, right? And I had very different, my doctors were telling me different things, right? My tough, burly surgeon was sort of saying, oh, just take one Advil, you'll be fine, right? And other doctors were like, oh no, you need, well, just continue to stay ahead of the curve. And interestingly, what became sort of my favorite friend was the pill cutter, right? So when I was at home, I controlled my own medication and when I did it and when I didn't do it. So if I wanted to take one pill because my pain wasn't so bad, but I needed another because it got worse, I could do that. And so gradually I started to cut my pills in half, and I would, start to layer in, maybe I'd skip around and do Advil instead. And, sort of gradually was able to wean myself off of the 12, but it took a long time to do. And I think that was for me a huge challenge, one of the huge challenges. I think another area, and this is probably very pancreatic specific, was around nutrition, right? So a lot of people who, after pancreatic cancer surgery, need enzymes to help them process food. And one of the key things is to figure out, well, do you need enzymes or not? But also how much and when do you do it? And it's literally, I would call it almost more art than science in terms of figuring out, sort of looking at what you're eating, figuring out, how much fat there might be, because the more fat, the more pills you might take. So, if I have a big steak and French fries, I try not to do, but if I do, I might have 4 pills, whereas if I'm having a salad, I might have 1 pill, or, cheese sandwich might be 2, so it's really takes time to figure out exactly how much enzyme to take and sort of how to take it with a meal, right? So, typically I might take 1 or 2 at the start of the meal, get partway through the meal, then have another one, because you want to sort of be in front of the food, if you know what I mean. You want to allow your body to sort of process the enzyme so it can process your food as it's coming through, right?
So it was a lot of trial and error then for you.
Absolutely, and I would argue that I'm still doing it to this day, right? So I need enzymes. I need a fair amount of enzymes, and I don't always get it right, but it's enough. And the downside is, the less the less effectively you process your food, the less energy you're getting from your food, and that causes a whole slew of other issues potentially that might occur. I guess the last sort of medical challenge, and this is just, I guess, really for everybody, is just along the lines of chemo side effects. And I know I had mentioned this to you previously that, for me, chemotherapy, knock wood, no nausea, no, like a lead stomach. And footnote, as I told you before, unfortunately to this day, if I go on a small boat somewhere, I'm going to feel it and I'm going to get nauseous. But, it took years for my chemo related nausea to catch up with me. I lost most of my hair. I had a bit of neuropathy in my feet. But for me, the worst part, and this was associated, I believe, with one of the medications I was taking, was something called soft nails. So literally, my nails became brittle, and I got sort of a bit squeamish because I could probably just sort of peel them back if I really wanted to, which I didn't. so I would tape them up. I was very protective to sort of make sure that my nails, stayed on. But that drove me crazy, right? That was, quite annoying to me to sort of try to keep ahead of that.
Mm.
So
And was that explained to you that that would be a side effect, before you took the chemo? I know they tell you what to expect.
not as much as I would have hoped, because
Mm.
then my question would have been, okay, so what can I do in advance to sort of, try to minimize or mitigate that problem? And there's some over the counter medications that are, that enhance strengthening your nails, right? So at some point I figured that out and started, but it probably would have been much better for me starting it at the very beginning. So for me, it's those sort of helpful hints that, your nurse practitioner and others, are a gold mine of information. Sometimes you just have to make sure you tap into them, because sometimes they just forget to mention those type of things.
Right. Or sometimes they're mentioned along with a list of many other things. So, they might pass over your head.
Oh, no
So,
doubt, no doubt.
yeah.
Which would, just as a side note, I would encourage all patients, right, when they're meeting with their doctors and others, right, to try to record those sessions, right? Ask the doctor, I just want to record this so I can go back over it and listen to it again later, particularly when you're initially diagnosed, because once you hear the words, "Oh, you have cancer," sort of everything in that rest of that meeting is mush, right? You don't remember a thing, and then you go home and you run on the internet, and that can cause its own issues.
Yeah.
But
That's
even,
a whole other talk.
right, but even conversations I would have with my wife, after going through an appointment, and she heard X and I heard Y, right? So it's always useful to both have another perspective, but also if you have the actual session recorded, then you can go back and listen for yourself.
Yeah. Excellent. So tell us how you ended up taking a chemo pill instead of infusion. I love this story.
Yeah, so this is interesting. So as part of the radiation treatment, what they do is they give you small doses of chemotherapy along with the radiation. And I remember, as I was heading towards radiation, I had an appointment with my oncologist, and she pulled out the pump and she showed me, the pump and how it would deliver continuous small doses of chemo. And you needed to get that dosing just right, because if it was off, then you wouldn't be able to do your radiation treatment. And I remember I just blurted out to her, I said, "Boy, that pump sure is noisy," right? And, it occurred to me, I would need it connected 24/7. I'd have to sleep with it. I'd have to shower with it. It was all kinds of inconvenient factors that came into play. And just sort of the type of person I am, I sort of did some research prior to my appointment with the oncologist. And I asked her and I said, "Well, isn't there a pill available that I could use instead of this pump?" Because if I'm completely honest with you, my quality of my life is going to suck with this pump, excuse my French, right? Because it's noisy. I'm not going to be able to sleep. I'm going to be irritable. Is there any way around it? And she said, "Well, yeah, yes, there's a pill." But she reverted to what I would call sort of the tried and true method, right? That, well, I've done this with a lot of patients. It works. No one has to miss his or her radiation treatment. You should do this because I know it works, right? And that if you do the pill, the dosing's a little tricky and it might cause you to miss something, and I don't want you to miss something. And I remember at the time, I just asked her one question, right? My question was, "What is the average age of your patients?" And she was surprised by the question, and she stepped back and thought about it and said, "Well, I don't know, probably around 70." And my comment was, well, I was 54 at the time, right? I'm a pharma person, so I'm familiar with this space. My wife is sitting there with me taking copious notes. And my question to her was, well, so do you think we can't follow any schedule you give us for the pill? So she put me on the pill, right? Now, again, most patients would not have that conversation to begin with. But for me, it was important because I knew the pump really would be disruptive for me, right? So I'm glad I took the initiative to have that conversation. And if my oncologist were here with me now, right, she'd tell you that I'm never shy about pushing her. So
And also you did some research ahead of time, so and you weren't afraid to ask the question, like, what's the difference? So,
correct. And
yeah.
at the end of the day, I think patients need to realize, okay, I'm not a doctor, right? They are better trained than I am. They know more than I do. But it doesn't mean you can't bring questions or thoughts or observations to the table that they might not be aware of, or there might be a very good reason why my doctor leaned one way or the other. But if you don't have the conversation, then you just sort of are relying on the wisdom of the doctor, which there are worse places to be than that. But yes.
Right. And I also think, there are many things about the cancer journey that are not in our control, and anything we can advocate for and take control of ourselves, I think can be very beneficial. So,
Absolutely.
So let's talk a little bit about non-medical challenges. So, what were some of the biggest things for you that you struggled with?
So probably the biggest for me was insurance and lack of coverage. So let me just sort of paint the picture. I've come through chemotherapy, and my doctor says, it would be worthwhile to do radiation treatment after my chemotherapy. And for me, because I had been a cancer patient previously, my body had been exposed to a lot of radiation. So I needed very specific radiation called proton beam, which is a very targeted radiation beam that literally goes right to the target and doesn't sort of bleed out into other areas of your body. So the doses are much more targeted. They're less invasive. And for me, given my background, that was sort of critical. Well, I could tell when I called my insurance company, I could visualize on the phone that this person I was talking to was looking at a table, and they were going, okay, pancreatic cancer, and then they look across the columns, oh, proton beam, and you come to the cell and it says experimental, right? And they don't cover experimental therapies, right? And even though I had one of the world's experts in proton beam radiation writing letters on my behalf explaining why, for me, it's not that it's proton beam and pancreatic. The real issue for me is, oh, he's had too much radiation exposure, he can't do that, right? But no, that was sort of their answer. And in essence, I challenged it 3 times. I appealed the ruling 3 times. Luckily for me, the contract that my company had with the insurance company, the final appeal was to an independent board of doctors who sort of reviewed the case. And their view was, no, it makes sense for this particular case, given your background, that you should be eligible for proton beam. Because, Erica, one of the things I found out when I had a conversation with the insurance company, I said, well, who's your internal panel of doctors reviewing this? Do you have sort of, a radiation oncologist on your panel? And by the hemming and hawing, I assumed that was a no.
No.
Right. And then it was, it was really along the lines of, okay, well, you understand what my doctor's saying about all this previous radiation. And I asked them, I said, well, would you approve normal radiation? And they sort of said, well, yeah, we would approve that. To which for me, then it was like, oh, all the more reason you should approve proton beam therapy for me, because that's all I can get. So it was very interesting. My wife would probably say, I got so mad that it sort of gave me a reason to have this fight with the insurance company. So, for me, basically it delayed my radiation treatment by a couple months, but, eventually I won. The other big challenge, and it's medically related, but it's what I would call sort of my new normal, right? And it's really sort of, well, how do I approach sort of normal life after I'm done with my treatments? Because my life's been far from normal. And, even to this day, I mean, every day for me, I wake up early and I literally go downstairs and I walk. And I walk, probably 5,000-6,000 steps first thing in the morning. And we refer to that as my settle time. I get a sense of what kind of day it's going to be. Is my body in a good mood or not a good mood? And what will I be able to do over the course of the day? So we love to travel, but travel's been a bit more constrained. I'm very aware of my GI challenges. I know where restrooms are. I know if I'm in meetings, I might sit towards the back in case I need to leave, and it just impacts the way you function in a normal life. So for me, I call it a new normal, and it's interesting because I know we'll talk a little bit about my blog. I blog a lot, and one of the challenges of that new normal is, well, I may look good, I may look like I'm recovered, but I'm not. I'm different. And you don't want to always wear a sign that says, oh, for old friends, hey, I'm different than I used to be, and here are my issues. And for new people who didn't know the old you're no different, but you're different.
Right. And sometimes we'll talk about that being like, people think it's like you had the flu, you're all better, you're the same you. So yes, you're better, but you're not the same you. It wasn't
Correct.
just the flu.
Absolutely.
It was cancer. Right. So what did you do about employment through treatment? Because this is a big part of your non-medical challenges, like decisions about what to do with work. So talk us through what you decided to do and why.
Yeah, it's very interesting because at the time of diagnosis, of course, I reached out to HR at my company and the benefits coordinator, and they assigned a nurse to my case. And they were all saying, well, our short-term disability coverage is really good. It's a really good benefit. You should do that. And in conversation with them, I started to understand, well, what it meant. And at my company, what that meant, first thing was, okay, well, we want you to really focus on getting better, that we're going to take away your computer, and we want you to just focus on getting better and on your care. And to be quite honest, Erica, I needed to work, right? For mental sanity, I needed something other than to just obsess about my treatment and how I was feeling and everything else. So I started to look around. I started to ask. I said, well, I want to work. What are my options if I want to work? And the HR people kept coming back to me saying, well, our short-term disability is really a good benefit. You should do that. Right. And I obviously saw I wasn't going to get any traction there. So I started to explore myself, and I sat down with my boss and we talked about, were there ways that I could work that he was comfortable with and I was comfortable with? And yes, there were. And so in essence, I sort of created my own benefit that other people could do as well. So I had 30 days of unused vacation, and that became my Whipple surgery and recovery time. And yes, it's the worst use of vacation days I ever did, but You got to do what you got to do. I then went on I didn't go on short-term disability. I went on family leave, which basically gave me the flexibility of I could work some hours a day, and when I didn't work, I wasn't getting paid. But, my boss was okay if I could make up hours over the weekend or where this was before Zoom and working virtual and all this other stuff where they sort of expected you in the office. And he was quite okay with me, trying to get to 40 hours as best I can. If I didn't get there, then, those hours I wouldn't get paid, and that was fine. So for me, that's how I tailored my plan, if you would. And the one thing I was very clear with my boss, I said, don't put me on projects where there's a critical timeline and I'm sitting in the middle of it. Because on any given day, if I just had my treatment 2 days ago, because my cycle was treatment Monday, Tuesday I felt okay, Wednesday, Thursday felt crappy, recover over the weekend, wash, rinse, repeat type thing. So yeah, I didn't want to sort of be that bottleneck because I just didn't know. I do my best to put in the hours, but I didn't know when I could put those hours in. So that was really sort of tailoring what I did when I was still working full time with the farm.
I think it's interesting how you considered your mental health as well as just how to work with your boss and and not just the financial side of the working. So
yeah,
it's creative.
Well, yeah, because I just knew I go crazy. And even to this day when I go back for periodic visits, if I stop by the oncology suite and people will remember me, oh, you're the guy who always brought his computer in and was holding meetings with your IV bag over your shoulder for 3 hours, with people. Most of my contacts were in the United Kingdom. So, it was that just became the way to do it.
Yeah. So since we're kind of talking about work, I want to take maybe a little side trip and ask about, so you've made some employment decisions post-treatment based on the changes cancer brought to your life. So can you share a little bit about that?
Yeah, I think my new normal was going to make it challenging, difficult to go back to work full time. But I could have. But I sort of opted to leave my company in 2016, and it was really to focus more on my health, right? And that's I really wanted to sort of try to get my new normal make it as good as I could get it, right? And then sort of as I started to recover, I decided, well, I was sort of ready for work, and I sort of started my own consulting firm. A, because it gave me greater control over my time, but B, it really started to focus more on, I don't like calling it patient advocacy. It was more about patient engagement and promoting patient engagement, because I bring sort of a different perspective than a lot of people to the problem. Right. I certainly, unfortunately, as a three-time cancer survivor, sorry, have that perspective. But as someone who's worked in pharma, as someone who's been involved with continuous improvement and process improvement activities, I sort of look at the problem a little differently. Right. So I do some consulting. I currently sit on multiple patient councils with pharmaceutical companies, with a health system, with a couple of internet startup companies, really to help, if you would, patients provide input and provide engagement throughout the entire, if you would, development cycle of new drugs, new treatments. So that has become sort of my focus to sort of give back.
Great. So I know there's been a lot of other post-treatment challenges, as any survivor knows. And we've talked a little bit about some of the challenges, but tell us about some of the other things you have had to deal with.
Yeah, I mean, it's been quite interesting. I mean, you know, they're ones that a lot of people experience, a lot of cancer patients, what's referred to as scanxiety, right? Which is really about, if you would, the anxiety that a person has as they wait for their next scan, right? So you go, particularly when you're done with treatment, you're sort of, okay, I'm getting a scan in 3 months. And then you go in and that's like, oh, well, that's going to be like Caesar deciding if it's thumbs up or thumbs down, are you okay or is it coming back? And you get anxious and you get anxious as you come into the scan. And then you get really anxious as you wait for the readout to come back to you to basically say, oh, you're good for another 3 months, another 6 months, or whatever period of time. So I think that's the constant for everyone. Um, for me, I've had a series of medical challenges, which for me, it's all connected, right? This is all comes back to the cancer. Um, for me, the hip bone is connected to every other bone out there, no matter how far away it is. And I've had a series, so there was a period of time, I visited the ER 11 times over a 12-month period. I was having internal bleeding. I was getting iron infusions and blood transfusions. I followed up where, I was losing weight. I lost probably 40 pounds and was having malnutrition and had to get, IV nutrition for several months. I started to build up ascites and other things. I had a procedure called GI anastomosis bypass surgery because of the bleeding. So a lot of things were going on that sort of made, if my oncologist would say, well, yeah, but I'm not seeing cancer, so no evidence of disease, no sign of cancer, you're cancer free. However, she'd be very quick to also say, yeah, but you have all this other stuff, which is very concerning to me. So, I'm not letting you go so easy, right? You're still under my care. At one point I spent, notice my words here, 50 consecutive days in the hospital for this internal bleeding stuff. And not nights, because sometimes I was sent home and then I would show signs of bleeding again and go back in the next day. I had a procedure that they call TIPS, which is typically, I'm going to try, transjugular intrahepatic portosystemic shunt.
Well, that's pretty good.
I think that's it. So basically, they put a shunt in my liver and a stent below to sort of help me with ascites, because ascites basically a buildup of fluid, and I ended up going, at first it was every probably 2-3 months, but then it became every month-ish, and they were draining 2 to 3 liters fluid out of me every visit. So I had this put in to help alleviate it, and knock wood, it's till recently has been pretty effective. And then I had a bunch of recently bacterial infections and other things, and requiring some hospitalization. So it's never a continuing battle. But again, you try to stay ahead as much as you can.
Yeah. Sometimes we think, gosh, the cancer, the gift that keeps on giving.
Absolutely. Never stop.
So I've kind of on a different subject now. I've spoken with many survivors who use writing as one of their self-care tools. Self-care is very important as we're dealing with all these things we just talked about, whether it's the scan anxiety or all these other things that come up because of the treatments we've had. So you have used writing as kind of a self-care tool and published a blog on the patient journey. So tell us kind of how that started and what that's all about.
Yeah, so interestingly, I started this when I was still working. So during my treatment. So I worked for GlaxoSmithKline, and I approached the communications department and said, I'd like to sort of write an internal blog during my journey. right? That sort of, and again, they didn't want, they were sort of, I'll say cautious, given the numbers I talked about at the beginning, right? They were sort of cautious about it. But we, so I didn't want it a lot, but I did 3 blogs internally, which I sent, which got published for the R&D community at GSK, which was where I was working. And, everything from the first one was sort of along the lines of the responsibilities of a patient, right? To, if you would, help doctors be able to help you. Right. So, hey, if you're not feeling well and you've got all these different things, right, don't sit on it for months and months and months, right? Go see a doctor, go get your physical, go do all these things to do it. So starting as sort of the patient has a responsibility, if you would, to be actively aware of what's happening with them and taking intervention when it made sense. And then I just wrote, 3 or 4 blogs for GSK for internal consumption. And after I was done, I was sort of like, okay, well, that was interesting. And, the feedback I got from the communications department at work was, your articles were by a mile the most viewed things ever. Right. And, it sort of struck me as, oh, okay, well, obviously there's an appetite at a pharma company, but I think, there was an appetite towards sharing part of my journey, if you would. So I then decided within LinkedIn to do something I called, through the patient lens. And basically it started with the GSK blogs, but then I sort of expanded, and now it's beyond just sort of my personal journey, so there are a lot of sort of observations about healthcare and opportunities for improvement, and some are quirky and funny, and some are deadly serious. But it just, for me, was good therapy, and it was another way to sort of pay it forward, because again, I have a unique lens as a patient. I have a unique lens as a former pharma exec. I have a somewhat unique lens of, process improvement and wanting to make things better. So I try to bring all that to my blog.
Great. So when I first met and spoke with Rob, he shared with me something that he wrote, which you heard it here first. It may make it to the actual blog on LinkedIn. And it was called The Evolution of a Patient as Seen by Hamilton, as in Alexander Hamilton from the famous musical. And I think that Rob had a great analogy between the patient and one of the scenes in the musical that happens to be one of my favorite songs in that scene as well.
No, I won't sing, Erica. No.
Oh,
sorry.
come on. So if we have any fans of Hamilton out there, I think you can really relate to this. So Rob, just kind of summarize and tell us kind of what you wrote about in that.
Yeah, it was really trying to sort of, if you would, compare and contrast patients to today versus, patients, I'll say, of the last century, right? So it really, when I sort of sat back and thought about it, what struck me, I remember, I remember where Aaron Burr sort of told his younger Alexander Hamilton about offering him some free advice and, talking less and smiling more, right? And for me, that reminded me of, if you would, the days when, as patients, we weren't very well informed, right? That we pretty much relied on our doctor and our doctor's knowledge. And yes, doctors are smart, but back in the 1900s, right, that they didn't necessarily have access to all the information they have today. And you might be with a specialist who's very current on treatments and options and other things, and that's great. Or you might be, if you're perhaps from a more rural location or others, you might be with say, an oncologist who isn't a specialist in pancreatic, but is a very good oncologists, right? But they don't see that many pancreatic patients, if you would, right? So for me, I sort of call that the white coat syndrome, right? Where patients just rely on the doctor in the white coat because he or she is knowledgeable, and of course they have my best interest at heart, right? And then sort of think about it as, well, yeah, but as Hamilton said, he wanted to be in the room where it happened, right? And he wanted to see how the sausage is made, right? And for me, that was sort of a perfect explanation or transition for where patients are today, right? So I think patients are, much more involved in the clinic as patients, as they're actively going through treatments. They're viewing the internet, they're talking to people, they're asking doctors questions. They're much more attuned than, say, my parents were as patients, back in the 90s. And I think that's a key thing. But I think there's another angle of being in the room, right? And what I'll call it sort of, if you would, the experienced patient, right? So someone like me, for example, who's been through pancreatic, who's been through the journey, who knows some of the warts and issues and challenges. So yes, I can work with various stakeholders to help them be better, if you would. I can sit with pharma companies and help them as they think about developing a drug from sort of start to finish, and provide them with perspective and insight of what the patient's thinking about and going through, right? I can sit with a hospital and say, oh, well, what can we do to make the patient experience better and more inclusive, within our organization, within our structure. So I think there's a lot of opportunity for patients really to be in that bigger room and really influencing what's done. And I would even, argue at this point, not even, it's beyond just seeing how the sausage is made, right? I would view it as, oh, well, we're starting to perhaps adjust some of the ingredients of the sausage, right? I like garlic, right? So I want lots of garlic in my sausage. So I think there's again, lots of opportunity out there. And, my guess is over the next, 5 years, it will be the norm. And just one other stakeholder is regulators, right? The FDA and others are much more keen these days to consider impact on patients as part of their review cycle. So they want to know that pharma companies and others are engaging patients, patient advocates, understand the disease and the challenges, and show how their medical solution, if you would, addresses those underlying patient needs.
Great. Yeah, I love that. So as Hamilton told Burr, you need to be in the room to get it to happen. Being silent is not good, is not helpful. And whether we're patients being involved in our treatment plan, or whether we're survivors being part of the advocacy for others going forward, I think I just thought that was a beautiful analogy.
Okay.
So I could talk all day, but we probably should wrap it up. So in closing, I was just going to ask you again to remind us of, you mentioned it earlier. I think it kind of sums up who you are and what the cancer journey, the kind of the gift it has given you. And that is something you referred to as your true North Star. Can you
Right.
Share that with us?
Yeah, so it's throughout the journey enabling patients to make informed decisions. And, I think as patients, we should be striving for that as we go through that. A lot of times finding all those options that you need to consider is not an easy task, right? But I think we owe it to ourselves to, again, I won't say challenge our doctors, but to challenge our doctors and say, well, have you thought about this? And have you thought about that? And I'll leave with one anecdote. Oftentimes when you ask the doctor, have they considered clinical trials? And the answer usually is, well, yes, we have, but standard of care is better for you. But if you ask them another question, which is, okay, but when you thought about clinical trials, where did you look, right? typically the response is, oh, well, we don't have any clinical trials available at our site that meet your criteria. Oh, well, if I'm a patient at Sloan Kettering, maybe there's something at Johns Hopkins that would be a good trial for me, right? So again, it's a matter of how much you want to filter your lens when you're looking as a patient. My lens is as wide as it can be, and then I might narrow it later, but it starts out very wide.
Great. And if we want to find your blog on LinkedIn, we could, what do you recommend searching for?
So you can either, I guess, search for through the patient lens, or more to the point, you can reach out to me and connect with me, Robert Wecker there, Weker, and you'll then find my blog all over there.
Great. Well, thank you so much for sharing and some of your personal journey and story. And thank you.
Okay, thank you for the time.